Up next, with great pleasure, I would like to invite Dr. Arun, Dr. Sridhar K. to the chair, consultant physician and diabetologist at DIA, Specialties Diabetes and Thyroid Center, Bengaluru. Thank you.
Good evening. I would like to introduce Dr. Basavaraj GS, who is a consultant endocrinologist, Narayana Health, Bengaluru. Consultant endocrinologist, Shashi Advanced Health, Bengaluru. So you'll be talking on Finerenone in clinical practice, transforming the management of cardiorenal complications in DKD. Over to you, doctor.
Sure. Thank you, Dr. Sridhar. Thank you for being so active in the highlight. And since yesterday he has been posting a lot of pictures and trying to keep up the motivation levels high. Thank you for that, and thank you for the zeal which you have taken up to pull out some traction towards RSS Day to be held in Bangalore. And every one of us know that it's going to be held in the tail end of this year. Please do come. Now, what we'll be talking in the next couple of minutes, rather I would like to keep a lot of time in discussion and try to take through the slides very quickly about one more exciting molecule, the Finerenone. The previous speaker spoke very well on the biosimilars and the biosynthetics. Okay, just a thought on that back. Biosimilars, any amino acid sequence more than or equal to 41 goes as a biosimilar. Any sequence, a peptide less than 40 amino acids, equal to 40 amino acids, goes as a synthetic molecule. So GLP-1 amino, the semaglutide goes as a biosynthetic, not a biosynthetic. It goes as a synthetic molecule, whereas liraglutide, which is longer, goes as a biosimilar. Insulin goes as a biosimilar, for that matter. Now, there are certain regulatory differences. So, but again, coming back to one of the patented molecules, I'll just get drifted away. You give me mic, I'll keep on talking. So, better that Finerenone, we'll come back to our topics. Finerenone, in clinical practice, transforming the management of the cardiorenal complications in diabetic kidney disease. So, we all understand that there's a huge burden of the diabetic kidney disease. Most of them go unrecognized. Even if they are recognized, sometimes we brush it off our shoulder, telling that no, it's okay, we'll see it next time. And I have done so many times. So that's fine. We don't follow them up because until now we did not have anything else to treat it except the RAS inhibitors, what we had, and the glycemic control and the hypertension control. Following that, we have got a couple of lineup of agents. We have the SGLT2 inhibitors having robust data for the kidney diseases. Then comes up is the Finerenone, what we'll be talking on. Is there an unmet need in the management of CKD and type 2 diabetes? We'll also try to focus on the MR, mineralocorticoid receptor overactivation, relevance of Finerenone, a mechanism of action in CKD type 2 diabetes, clinical trial programs, one of the biggest of the clinical trial programs, and pillar-based approach for CKD in type 2 diabetes. Cardiorenal protection, importance of early diagnosis and of intervention. So CVD burden in type 2 diabetes, there is 2 to 3 times increased cardiovascular disease risk in patients with diabetes. We understand that the heart attacks risks are higher rates of hospitalization, higher rates of survival, reduced rates of survival are seen. The incidence of kidney diseases is 10 times higher in people with diabetes than without, and the prevalence of albuminuria is close to 30 odd, more than 30-35% of odd. And expected life, how much life are we lesser here? Shorter life expectancy, we understand with diabetes, average we tell that the life expectancy goes down by a decade. So if the average life expectancy, let's say 70, it goes down to 60. So that is how is one of the conversation tool which you have to talk to your patients, that controlling your sugars, controlling your diabetes and the complications is definitely going to improve this decreased life expectancy. This is general. Again, don't scare the patients. Probably you have to tell that this is overall a general view, and then probably you'll have to look forward and try to see how this works. So early CKD, if someone has within 5 years of the diabetes, it has to be probably around 6 years of life expectancy is decreased. With diabetes, around 10 years, And with early CKD and diabetes, it goes up to almost 15 years of decreased life expectancy. So why is the assessment of albuminuria considered crucial in type 2 diabetes patient? Of lately, I think all of us, we do creatinine once a year. Show of hands, at least once a year. Yes, majority of us. How frequently do we do USCR? Again, show of hands, at least once a year. Yes, perfect. I think in a position in a city like Bangalore, I don't think we have any issues with the accessibility, or rather, to a large extent, I would not generalize again, to a large extent, affordability for doing a USCR at least on a once a year basis. So, but then again, USCR becomes one of the very, very, very prime important tests to pick up early diagnosis of CKD, plus the reclassification of the CKD into the various grades and categories. We all understand about the presence of albuminuria. Mild to moderately increased is more than 30 milligram per gram of creatinine, and eGFR of less than 60 is considered as a reduced kidney function. So now we take an example of a farmer. The farmer seems very happy. He has had a very good, nice harvest year. He goes and checks his sugars and everything. His eGFR comes to 62 ml per minute per 1.73 meter square of body surface area. I still remember my MD Professor Dr. Sanjay Jain from PJ Chandigarh. I used to always tell 62 ml per minute. And then one day, he hit me very hard with his hammer, telling that 62 ml per minute per what? He is the guy who has written majority of the hypertension guidelines per what? Then I was perplexed. Then he told per 1.73 meter square surface area, body surface area. So that is important because this is dependent on the body surface area. So that is what again I come back again and tell. So this patient, when we see, he appears to be very, very of a milder risk. So this is 62, G1 or G2. Then if you just do a USCR and it turns out to be 350, exactly Raman sir, shifts, the risk shifts. And then you start getting goosebumps. Oh my God. Come on, man. This can't be true, Anta. So talking in the Gen Z languages. Now I've spent a whole day with my kids, so I'll be doing more 6, 7s here. But yeah, then again it goes way back here. And then what we have to understand that eGFR particularly is something like you don't track it yearly. And again, because you don't track it and keep a record, you don't progressively see it, you don't see a decline very quickly. And then with the variability of the assays, patient doing 1 mg, doing somewhere else. Of lately, just a patient came. Doctor, we did it and the creat was 1.7. Then he underwent an angiogram. Creatinine now, the cardiologist asked me to do. Now it has come as 1.1. How is it possible? I'm like, it's not possible. You just have to repeat it once again to cross-check. So all of these things are the Indian things which we have to understand, that there cannot be very standardized assays and we'll have to run around with these problems in our systems, but quite robustness which we have to develop. It's again our responsibility. But one of those things what we have to understand, apart from the eGFR, is albuminuria is parallelly going with the fibrosis. So albuminuria reflects the underlying fibrosis which happens in the kidney. So tracking albuminuria is one of the most important aspect in the management of diabetic kidney disease per se. So, okay, ultimately the patient is going to die by a heart attack. How is it going to matter if I'm going to just check the albuminuria? Because albuminuria predicts your mortality. So check the albuminuria. So even at a lower level of 30 milligram per gram, it also predicts cardiovascular death and all-cause mortality. This is again a data from more than 3 lakh hypertensive patients. So if we see what they tell is, at least on a yearly basis, try to check or check compulsorily eGFR and USCR. So couple of things with the USCR. Don't jump the trigger with a single value. It has to be persistently high, more than 3 months apart, is the classical definition of proteinuria or albuminuria. 1. Rule out fever, rule out menstruation, rule out heavy exercises, rule out congestive heart failure, and high sugars, catabolic sugars, 300, 400 of sugars, you check a USCR. Because USCR most of times is done by a immunoturbidimetry, which interferes because of the hyperglycemia. So be a little bit careful with all of these things. And then once you are clear that none of these things are there and persistent albuminuria is there, the patient is definitely at a higher risk of all-cause mortality and for all the complications. So all the drivers of CVD and CKD progression being addressed. Yesterday we were talking a lot about semaglutide when I was here in the other hall in the evening. But what we understand is that one of the basic factors which we are neglecting pathophysiologically is the MR overactivation, the melanocorticoid receptor overactivation. That is again because of the high aldo and the cortisol and oxidative stress and the high albuminuria causing MR overactivation, and all of this leads to kidney failure and definitely heart failure. So a wonderful molecule, Finerenone, blocks the recruitment and binding of transcriptional factors, conformational changes in the melanocorticoid receptors occurs, and then that leads to MR overactivation blockade, gives a good kidney and heart protection there. So Finerenone is a bulky, non-steroidal and a selective melanocorticoid receptor antagonist. So we all have used spironolactone, eplerenone and Finerenone, and we keep using in gynecomastias. We see gynecomastias with the usage of spironolactone more than that of eplerenone, none with Finerenone because it's again a selective melanocorticoid receptor. So now 4 important drugs which are available for the management of CKD is: 1, we all understand the classic role and the proven robustness of the RAS blockers, your antihypertensives there. Second in the line is your SGLT2 inhibitors, EMPA, DAPA, all of them have been shown to be very nicely handling the CKD burden in diabetes. Then comes your Finerenone. This decreases inflammation, fibrosis, endothelial dysfunction, tissue modeling and proteinuria. And then definitely GLP-1RA, with the flow trial coming in, the 4th pillar would definitely be semaglutide there. But where do we stand? There is definitely a residual risk in spite of doing all of these things. In spite of renal is a losartan based trial, IDNT is an irbesartan based trial. So both of them treating your hypertensive to a good extent in trials showed the residual risk which you can see in the gray zone there. Credence, after adding SGLT2 inhibitors also, there was residual risk which was persistent there. The same residual risk is DAPA-CKD and EMPA-KD. That residual risk minimization or blunting is what we all are aiming here to do. So we have got the Finerenone's cardiorenal benefits. The trial are called as the Fidelio trial and the Figaro DKD trial. Together it's called as a Fidelity trial. One of the biggest of the trials for kidney outcome trials, 7,000 patients were added there. It's bigger than the EMPA kidney trial. Together, if you see, it's more than 12,000 patients together, one of the huge biggest of the trial seen in the whole of this CKD and the type 2 diabetes. In short, we can call it Dhurandhar of the CKD trials. Yeah. Then again, Dhurandhar 2, how many of you have seen? Coming back, perfect. Dhurandhar 1? Oh, perfect. I am the only one left out. So today I'll have to do binge watching then, Dhurandhar 1 and probably 2. Okay. Sir? One mugustin, sir. One mugustini. Amal nodan two. First, let me finish the step 1. Yeah. Sir? Perfect. Okay, done. We have got a very resourceful hall here and nice. Thank you. Okay. So then again, there is this pooled analysis of Fidelio and Figaro DKD trials, which has got 13,000 patients from stage 4 to stage 1 to stage 4 CKD. And then if you see, majority of the patients were either A2 or A3. So mostly 95%, more than add it up and then it boils down to 97% of patients have A2 or A3 proteinuria, and then at least a vast majority had G3 and above. So the creatinine was less than 60 in more than 50% of patients, and more than 90% of them had average proteinuria of more than 30. So now coming to that average, USCR was 515 milligram per gram. Mean eGFR was 57, less than 60. Median potassium was 4.35. Now, one of the most important points what we have to understand is, much of these patients were not on the SGLT2 inhibitor in spite of being CKD patients, because that time SGLT2 inhibitors were not standard of care. So that is the reason why you can see that only less than 7%, around 7% were there on the SGLT2 inhibitor and on the GLP-1 analogs, but most of them were on ACE-ARBs and also the statins. So this led to the trial of Fidelity, wherein there was a 14% relative risk reduction of the composite cardiovascular endpoints, predominantly again driven by HHF, heart failure hospitalization, and then composite kidney endpoint, 23% relative risk reduction, an NNT of 59 over 3 years, and NNT of 46 over 3 years to prevent one composite CV endpoint. So then we understand that Fidelity told us that there was 22% reduced risk of first HHF, 32% reduced risk of new onset HF, and then ESA 2023 came out telling that Finerenone can be used in patients with CKD and type 2 diabetes to reduce the risk of HHF, class 1A indication. That's very strong. So the mean USCR reduction was close to 32% over a span of 48 months, 2 years. So USCR decreased by almost 27 to 30% between baseline and month 4 versus placebo, and then that gradually tapered down to 27%. Now, there were a small bunch of people, those 7% of people who were on SGLT2 inhibitor, they were close to 800 plus 877 to be very specific. Now, what happened was the median USCR decline was higher in patients who used both SGLT2 inhibitor and the Finerenone versus 31% in patients who used the Finerenone alone. So, if you see, then again the chart also, the diagram also, that overall the composite endpoint was better with or without SGLT2 inhibitor. Kidney composite, HHF, all-cause death were all better. But again, statistical significance was only seen with HHF there and not with anyone else. So then we'll come back again to that, the point of SGLT2 inhibitors. Adverse agents, not much. Hyperkalemia was seen, but then again it was all manageable, and a maximum potassium difference of 0.2, not more than 0.2 millimoles per liter at month 4 was there. So high baseline potassium, lower EGFR, higher USCR, and beta blocker usage leads to higher risk of hyperkalemia. So the pillar-based management of CKD in type 2 diabetes, again insights from the confidence study. Confidence is something, one of my, again, very close to heart, very nicely designed study, but again we can discuss or debate about the pros and cons in probably some other talk here. But then again, to finish the job here, Finerenone and empagliflozin started simultaneously in people with CKD versus Finerenone alone versus the empagliflozin alone, and then they were followed up for 180 days. A short-lived trial, small trial, 180 days trial of 818 patients. What happened? The characteristic was similar. The mean EGFR was 54, there it was 57. USCR was 579, there it was 516 or 17. Similar kind of picture with that of the Fidelity. And then, but here, simultaneous starting was there. GLP-1, if you see here, there was 23% of people on GLP and had a decent number of people with hypertension, ASCVD and diabetic retinopathy. If you see numerically, there was lesser reduction in USCR within 14 days of initiating combination therapy by almost 30%. Significant reduction in USCR reduction versus, that is your simultaneously. Matlab, one patient just got Finerenone, one patient just got, one group just got EMPA, the third group got EMPA and Finerenone together. So EMPA and Finerenone given together had a better USCR reduction than that of each of the groups taken together. And that difference persisted even at 180 days also. So there was quite a good number of patients who reached this more than 30% USCR reduction, 40% USCR reduction, 50% USCR reduction in these patients. Yes. But the challenge here was that the USCR reduction was also seen concomitantly with a decline in the blood pressure. And also there was a transient decline in the EGFR, transient decline in the blood pressure. All in all, that returned back to baseline after stopping the drug. So that was transient is what they tell. But only thing what we have to ponder back again is that whether the change in the USCR was because of the decline in the blood pressure is what we'll have to look at it. But then again, there are longer trials which we have to see. Again, that the changes were probably hemodynamic and temporary there. Hyperkalemia. And then again, we have again spoken a while about the caliuretic effect of SGLT2 inhibitors. SGLT2 inhibitors remove potassium in the urine. So it was a thought that probably the hyperkalemia, which was caused by Finerenone, would be offset by the empagliflozin, but it wasn't true here. What happened was actually the hyperkalemia was similar to that of the Finerenone's alone group. Then probably that was because of the transient decline in the EGFR, or the cause needs to be known, but definitely for sure simultaneously starting of Finerenone with EMPA does not cause hyperkalemia more than that of the Finerenone alone. So it's a safe strategy to begin with. So confidence, an early reduction in the USCR, which was significantly greater than with either agent alone, and additive reduction in the USCR up to 52% was seen, and 70% of patients achieving an ADA recommended target of more than 30% USCR reduction, and overall adverse event profile for the combination was similar to that of the either agent alone.
Doctor, yeah. Time.
Yes. So just I'll go to the last slide now. This one potassium thing, how do you manage about the potassium? If it's 10 milligram, potassium is less than 5, start on 10, follow the EGFR, monitor potassium, and then you can start on 20 also if it's less than 5, and then adjust the dose, and then if the potassium is less than 5.5, increase to 20 if the albuminuria response is not there. Sure. And then key takeaways, guidelines recommend both EGFR and USR testing at least once a year. Early CKD management is very crucial. Despite standard RAS blockade, addition of SGLT2 inhibitors and Finerenone definitely adds a lot of value, and Finerenone targets MR overactivation and effectively slows both heart and kidney fibrosis and the disease progression in type 2 diabetes patients. So I think this is the gist of the story. With this I'll end, and I would also want you to welcome to our annual event, Beacon, to be held at May 9th and 10th, 2 days scientific extravaganza. Please consider this as your bucket list for the month of May. Thank you.
Thank you, Dr. Basavaraj. I think it was a wonderful narration on the CKD, and also he has briefed on the confidence study. If there is any questions, probably due to lack of time, one question probably we can take, if there is any questions.
One more molecule after Finerenone has come. What is that? Recently they have announced. Better than Finerenone.
Which one is this, sir?
I don't know.
Failing to.
It has come about 2-3 months ago.
Okay, I'll try to understand more about it. Sure.
Sir, this supposing somebody is having a EGFR of 70, as the age advances, creatinine remains same, but EGFR calculation shows it is say 60 or 65. Does it indicate a deterioration of renal function, or?
Correct. If the patient is a poor controlled diabetes, and if it's probably more than 3 ml, if the movement is more than 3 ml per minute per 1.73, that we consider as a rapid decliners. But in elderly people, how much is it going to decline with span of time? We'll have to go back and look at the literature, number one. And if USCR is on the higher side, and definitely in elderly, and if the longevity is still preserved, if it's a well kept patient who is going to survive for good 10-15 years, then definitely consider and evaluate for further kidney damages in them.
I have about 20 patients on Finerenone.
Okay.
And all of them have responded very well to
very
this
well.
drug. From as much as 2.7 milligram, it has come down to 1.2 or something like that.
Sure. Hyperkalemia, what was your incidence of hyperkalemia, sir?
No.
Not much. Yeah, similar here. It goes, but goes up to 5.5, 5.6, 6 sometimes, but CKD patients tolerate hyperkalemia very well. So I think you just hold on at 10 milligram, don't escalate keep it at there. Once it comes down to 5.5 and patient is stabilized, so then you can probably start thinking of adding or going up on Finerenone if the USCR is still persistently high. Yeah, thank you.
Thank you.
What is that, sir? Okay. Okay.
Moleculars Isaxarenone.
Okay. Let's read about this.
I don't know what-
I'm new to this, so
I think
yeah.
that is the answer that sir was looking at, probably. The
Probably yes,
molecule
I think
which,
that's what is.
Okay, thank you.
Thank you.
Dr.
Thank you all.
Basavaraj.
Thank you.
Over to the program coordinator.
Give them a good round of applause. Thank you, respectful speaker and chairperson, for the great session. The practical takeaways on Finerenone and its role in DKD were really useful. I request you to proceed to the selfie stand for a photo with the memento.